Hello everyone and a warm welcome to this exclusive Our Space webinar. I'm Heidi and on behalf of Families of Veterans Guild and our presenters Gwen Cherne and Dr. Cowlishaw, we're delighted to have you here with us today. The Families and Veterans Guild's mission is to provide the defence and veteran community with a voice to facilitate access to services, entitlements and support and their social and emotional wellbeing. Our Space is delivered through a social work and wellbeing programs and offers regular online events such as this webinar to its members. To find out more, please feel free to visit their website www.familiesofveterans.org.au. Before we begin today's session and while everyone is logging in and getting settled in, I'm just going to go over some housekeeping. First and foremost, please be advised this is a webinar will be recorded. This is to ensure that those who couldn't make it here today can catch up later or share the valuable content with their friends and family. Now, throughout today's session, we're going to have some questions and I encourage you to pop your questions in the Q&A space that is in the webinar, and we will have a couple of opportunities throughout the presentation to present questions to Gwen and Sean to address. So it's now time to get started into the much needed conversation. And before I kick it off, I'd just like to remind everyone of a content warning. The up and coming discussion may touch on some emotionally challenging and distressing triggering content. If this content raises any concerns or issues for you now or in the future, please feel free to speak with your manager or make use of any contacts below, your GP or other health professionals. 1800 Respect, Men's Helpline or Open Arms. Thank you. I'd like to introduce Gwen Cherne and Dr. Cowlishaw. Sean, I'll hand over to you. Thank you.
Thank you very much, Heidi, and thank you everyone for taking the time this afternoon. This is much appreciated. As Heidi says, this is an incredibly important conversation to be having, and we're really glad to have the chance to speak about it today with you. Before we do get moving, I would just like to acknowledge the traditional owners of all the lands we join on today. Monash University, who I represent as campuses at various points in Victoria, which are on the lands of the Kulin Nation, and I'm joining you in particular from the lands of the Wurundjeri people of the Kulin Nation, and we pay our respects to elders past and present. And Gwen, I think the next is yours.
Hi everyone, good afternoon/evening. I'd also like to extend that thanks to all who served in our Defence Force and the families who sacrifice and support them every single day. We acknowledge the unique nature of military service and the sacrifices demanded of all who commit to defend our nation, as well as those who support them. I'll now go into our seminar overview for this evening. We'll be going through our key terms and context so that you're aware of sort of where we're coming from, why this is relevant. Sean will then go on to talk about the recent research that was released on IPV in military and veteran families and talk a bit about things behind the statistics. We'll also go through that lived experience and expertise from experience, our policy responses and future directions, and we'll make sure that we have time. There will be a couple of breaks in throughout the seminar this evening where we will be answering questions. As it is a live feed, put them in the chat and those will come through to Sean and I, and during those question times we will hope to answer them, and if not, I'm sure that Sean and I and our team would be happy to provide you with answers to your questions if we aren't able to get to them tonight. So with that, I might kick back over to you, Sean, and get started.
Okay, thanks very much, Gwen. So just to get the ball rolling, I will spend a little bit of time just speaking about some key terms and context, really just to set the scene for what follows. Now, the presentation today will be focused in particular on intimate partner violence. Now, in a moment, you'll see a definition on your screen, which is the definition used by the World Health Organization. And from this context, intimate partner violence refers to any behaviour within an intimate relationship that causes physical, psychological or sexual harm to those in the relationship, and references both current and former relationships as well. Now, this includes acts of physical and sexual violence, as well as dimensions of emotional abuse, and particularly important and salient in this context are what we describe as coercive and controlling behaviours. Now, these are often understood as being the context for other types of violence, but refers to acts including, for example, isolating a person from family and friends, monitoring movements, restricting access to financial resources, employment, education and medical care. And the key notion here is that these coercive and controlling behaviours are attempts to limit the autonomy and freedom of the victim survivor. Now, if we move on to the next slide, I'd just like to unpack some of the key terms and assumptions that we're making today. So when we, and for purposes of the projects that we'll be speaking about, have used the term intimate partner violence, we've really used this as an umbrella term. So as an umbrella term which encompasses violent behaviours that occur in that context of coercive control, as well as behaviours that are not necessarily motivated by those power and control dynamics. And the reason for this is certainly in the military and veteran context, there's actually much that we don't know about the nature and the context of violent behaviours. So we've really used this term broadly. And just worth noting, this can and often is different from how groups and individuals in other sectors might use the term. So, for example, those who work within the family violence sector often use the term intimate partner violence or family violence to just refer to the coercive and controlling behaviours and forms of violence. So we'll be talking today about some statistics, and throughout I'm going to sort of really try and be clear about where we know things about, for example, coercive and controlling behaviours and where we don't. And just to set the scene, there is a huge amount that we actually don't know, because we'll be talking about some very preliminary Australian research. So just to flag this in the sense that it's really important, so I think, to be sort of really clear and precise in terms of what we mean and what we don't mean, so we don't arrive at misunderstandings. We will be talking today about two different dimensions of violence, which is both exposure to violence. Now, we'll be using the term IPV exposure, people have been exposed. There are many other terms that are used variously in different settings and contexts, often the terminology referring, for example, to victim survivors of domestic violence. And we'll also be using the terms IPV use. So people who use IPV in some settings described as perpetrators of violence. None of these terms are perfect, but we have sort of settled on using the terminology of IPV exposures and use, and we'll again try and be really clear about which ones that we're referring to as we speak to them. And the final term I'll just note is that of family violence. So family violence is a broader term which encompasses intimate partner violence as the most common type, but can also encompass other types of violence directed between and across family members, which includes child exposure to intimate partner violence, child abuse and elder abuse. The focus of the work that we'll be speaking about today is mainly on intimate partner violence. Now that doesn't dismiss the importance and the significance of these other dimensions of violence, but as noted, this is some really preliminary work, and to some extent we've had to manage and work with the data that we've had available, which has been about intimate partner violence, and I guess to some extent we've also had to start somewhere, and that has been on the most common type of family violence, which is intimate partner violence. Next slide, please. So I'm going to start speaking about some of the broad policy context before I hand back to Gwen. But I guess I just want to speak about this in a little bit of a timeline here. So there's three really major policy initiatives that are important to highlight. And the first was the National Plan to Reduce Violence Against Women and Children. So this was the first national policy framework for actions and investments in relation to violence against women and children, which includes, as a major form, family violence and intimate partner violence. Now, this the first national plan was published back in 2010. So it has been superseded more recently, back in 2022. But just to note that the sort of first major attempt to coordinate policy actions here across states and territories, and as well as the Commonwealth government, has its roots back to activities in the sort of mid-2000s and the publication of that national plan in 2010, which had a 12-year window. Back in 2015, there was also a Royal Commission into Family Violence in the state of Victoria. And this is important to highlight, firstly, because it draws attention to the fact that within the family violence space, many of the services, the policy frameworks and responses have been organised on a state-based level. And those states vary in terms of the level of development and the resources that have gone into family violence prevention, early intervention, response and recovery models. And I think many would argue that the Royal Commission into Family Violence, which was published in 2015-2016, was really the most serious undertaking in that space in an Australian territory. There were 227 recommendations from that Royal Commission, which have now been all implemented wholly or in part. And one of the big initiatives in that was the Family Violence Multi-Agency Risk Assessment and Management Framework, the MARAM. So many of you may have heard of this, but this was some sort of really groundbreaking sort of policy work that went into, amongst other things, a whole bunch of training resources for different types of service providers and online materials for developing capacity, but also some legislative infrastructure. And this legislative infrastructure, for example, provided the legislative framework, for example, for information sharing, to actually support and enable that family violence identified, for example, in a child protection setting or in a sort of mental health setting, for example, could be shared across different service sectors. And there was a legislative framework for doing that. Now, that exists in Victoria, and we're now only starting to see in some of the policy discussions about how to actually extend that at the national level. So just to highlight that some of our states and territories are at different places, which has interesting implications. For example, when we start thinking about services such as Open Arms, which does have that national profile, but operates in different states and territories. And the final thing I would comment on is the 2022 to 2023 National Plan to End Violence Against Women and Children. So this is the most recent iteration of that national framework, a 10-year window, and there's a few parts of that are particularly important to highlight. One of which is that the national plan now commits Australian states and territories to action across 4 domains of activity, and this includes prevention, early intervention and response, but critically also recovery and healing. So really focusing on sort of the aftermath and recovery from family violence as a major form of trauma and social disruption. It recognises that data is really crucial to both understanding the problem, but also measuring progress. And finally, it also acknowledges for the first time as a distinct group military and veteran families. And one of the reasons that it does acknowledge that is because of the significant advocacy and work that was done, in particular by Gwen. So Gwen, with a view to that, I might hand across to you to take us through to the next step.
Sure. So as Sean was saying, in that National Action Plan, we did an enormous amount of work with Monash University and a number of PMC and a number of others to make sure that veterans and families were considered a unique cohort in that national plan. And what that's done is allowed us to actually be seen as unique, actually have specific and different layers on top of, because what we were hearing along this process of the creation of the National Action Plan was that veterans and defence were just like any other employer or any other civilian. And it was really important that we shed some light and open up what many of you on here would understand is that unique experience, the double isolation that many of our families experience, the constant changing of environments and therefore a struggle to connect with community, some of the entitlements within defence and within DVA that allow for coercion and control to be a ripe environment for family domestic violence, as well as the intimate partner violence that we know about, the fact that veteran families have a higher threshold for tolerating pain, anger, and violence than other communities, and that these things were really important for us to flesh out for government to understand across both federally and statewide. So we felt that this was a really important initiative that we took up in 2022. The national plan, if we might move to that next slide, the National Action Plan has 10 actions, which are incredibly important. And if you haven't familiarized yourself with them, they are relevant to you and your work. And they are a commitment by government to actually improve and reduce that violence against women and children. But the next section, the next slide here that we have actually shows how these are, if we could just move to that next slide, thanks, sorry, moving ahead. The 5 listed here are all relevant to veteran families, and they really focus on things like education, destigmatization, research that is really important to do, investigating screening tools that would enhance early intervention in this specialist workforce, capacity tools for outreach program counselors so that they can actually manage intimate violence and family domestic violence concerns and help families to heal. They will go further later on into what DVA and Defence are doing in some of those initiatives as well. So I might leave that till later, but I wanted to make you aware of the fact that the Department of Veterans Affairs and Defence have put things in toward this action plan, and it's important to be across those if you're working in this sector, and some people are aware of them and some aren't, so we just wanted to make sure that you were informed. I might pause there and hand over to some questions if we have them at this point before we go into quite some depth on what the research that Sean and his colleagues did on IPV.
So Gwen, there's no questions at this time, but
Okay.
I'm just going to throw back to you and Sean and see if there is anything in particular that you think is really important for our veteran community that they should be made aware of through this policy context, through this policy lens.
Look, I think for me, it's probably that we have a really great opportunity. We have a great opportunity to say, this is the concerns that this community has, and to actually shine a spotlight and seek funding for programs and support in a way that's actually meaningful for our community, in a way that actually addresses the fact that veteran families often get ping-ponged back and forth between Defence and DVA on one side and the civilian community on the other, where you seek support from one and they send you back and forth. So in order to stop that, we're really looking at some of these actions and a number of others to ensure that military and veteran families are better supported now and into the future. Sean, did you have anything to add there?
Yeah, thanks, Gwen. So I think for me, where these policy, we start talking about policy frameworks, it's often a bit of a, okay, well, what is that likely to do? So where I think these are really important, particularly in the sort of the national level, is these really have an orientation towards holding government to account. So DVA, Defence, like many other types of organisations, I know we had challenges in for example, the primary care setting for many years, where there are so many issues competing for attention and resources. How do we make sure that these issues maintain visibility and get prioritised? So having a national plan which does acknowledge and recognise military and veteran families, which speaks to the need for prevention, early intervention, response and recovery, I think, you know, is a really important foundation for much of the work that's going to follow from this, because it will ensure, hopefully, that these issues don't fall off the agenda and they don't fall off the radar. And as Gwen highlights, that they are a priority for resources, because doing something about this problem is going to be expensive and it's going to require comprehensive responses.
Just before we move on, we've just had a question, and thank you to those that are starting to pop their questions in the chat. If someone were a victim, is there a way that they can share their first-hand experience to assist in making change and driving change? Do you guys have any recommendations on how they can get involved?
Sure. There are a lot of, I actually on a regular basis get individuals who reach out to the my office, the VFA at dva.gov.au, and share those case studies. And what happens is we share the de-identified information at once approved by you or having your consent, with DVA policy teams, with the executive management board, or even as high up as commissions on a number of cases, so that they can understand the fullness of people's experiences and what those policies are doing, or how they're encouraging family and domestic violence, intimate partner violence, or coercion and control. And so we recently, for one example, used a number of cases that we saw for the acute support package, and we got, I think it was 18 different cases where people were struggling with this particular package that DVA was providing. And what we did was use that to advocate for and show the executive how this package was and wasn't working in a way that we thought it should. And we were able to amend that. We were able to change policies and develop policy frameworks that were clearer for those actually administering it. So absolutely, if you'd like to send that through, as well as later on, I'll talk about some of the webinars that we're doing later on in the community of practice that exists, that we can use that knowledge in. Oh, over to you, Heidi.
Okay, we'll have 2 more questions before we start moving on, guys, and thanks for jumping in the chat. Do you see a role for the peer workforce that sits outside of the mental health peers at Open Arms at this stage?
Sorry, just to repeat that question, do we see a role for the peers in intimate partner violence? Look, I think it's an interesting question. I do know that they bring in lived experience and sometimes may or may not have experiences as a child or experiences as an adult with intimate partner violence. I do know that the frameworks around what Open Arms is doing and the model is being reviewed and revised at this moment. It is a good question to take to the National Advisory Board for Open Arms, but also we are looking at how DVA addresses this as well. And so I think as a whole, it's a question that will be developed into the future. Yes.
I might just jump in as well, Gwen, and just like a resounding yes. How we support that workforce to do that safely and appropriately, that's the challenge in front of us. I think what the national plan, with that sort of focus on prevention, early intervention, response and recovery, as well as cross-sector engagement, highlights, you know, we need every workforce, we need every group to be sort of looking at these issues and sort of really, we need to figure out how we can mobilise these resources to improve safety for women and children. But we also need to be mindful that these are really challenging problems, and you know, different workforce groups, for example, require support. So I think Gwen's point about, you know, how we, for example, engage DVA in order to build some of those support structures to allow this workforce to engage more fully and safely and effectively. And I think that's also probably where that sort of lived experience voice comes in. You know, we need we need people such as, you know, sort of people on this call and yourself, Gwen, to be continually advocating for this and identifying the opportunities for providing support and opportunities for enhancing safety.
I might just making sure you can hear me. Yep, great. I might just add one thing to that. And one of the things that I advocate for consistently across all of the family and domestic violence work that I do is two things. In the family and domestic violence space, in my experience of it, there is real limitation and stigma around lived experience as service providers. And there is still a struggle to be inclusive of men. I consistently go to events that are national events where there are 300 women in the room and 20 men. And so until we invest genuinely in and start removing that stigma around the inclusion of lived experience and the inclusion of men in solving this problem, we will not solve this problem. So I definitely think the inclusion of lived experience in all things in policy decision making, as well as service provision and how exactly what you were saying, but as well as men in those solutions, we're just going to be in the same place we are right now.
Gwen, okay, last question before we move on, and I'm going to pose it to you, Gwen, because you're probably more familiar. Is Defence willing to discuss as a live issue with a very long historical tale about FTV and IPV? Do you feel?
Look, I absolutely, and I will talk a little bit later about some of the work that they are doing. And I frankly don't think that the Royal Commission is going to give us a choice and the government is going to give us a choice anymore. It is something we have to talk about, we have to recognize, and we have to look at the services, the policies, as well as the structures, both in how they affect the family domestic violence, suicide, and intergenerational trauma. And these are things that as a nation, we just aren't going to stand for anymore. So I do think the commitment is there. And now I do believe that the commitment that, at least in the conversations I've had with Defence, the DMFS, Natasha Fox, and others are committed to doing this. What that looks like and how it rolls out, is still a work in progress. And I also think that we all need to, from the outside, keep fighting for change, because the more pressure our government feels, the more able the policies and programs and services we want to see are going to come about.
Thank you for that, Gwen. We're going to come back to questions later, so I'll get you to continue with the research on the IPV.
Great. So Sean and his colleagues did an amazing job a couple of years ago on some IPV research, which you may have seen. And I really think that this has changed the conversation. It went from anecdotal and well, frankly, we had all the qualitative data in the world that we wanted. I think sometimes naysayers need hard evidence and they need numbers in front of them to understand exactly what we're talking about and to validate what families have been saying for decades. And that is that family domestic violence and intimate partner violence are no stranger to families in the Defence Force and those transitioning, as well as those who are out. To give you, I will let Sean talk you through all of his fantastic research. But it's the first time that I feel like we're getting traction on this in our community. And I'll provide some context here. We have, a military which, frankly, they are war fighters. There is a hierarchical organizational structure that reinforces command and control environments. We are obviously, as I said earlier, frequently relocated, doubly isolated. It is a hyper-masculine environment. These are high-risk jobs where there's workload is exhausting, there's bullying, there's interpersonal conflict and combat experiences, families who have to survive without them, and then they go away and come home and try to reintegrate, which is a recipe for stress and tensions. Now, the thing that we don't often talk about as well is emotional regulation, the foundations of functioning, interpersonal relationships, and these things being at the basis of what makes for good relationships. And our community in this hyper-masculine, highly controlled environment, often that does not translate to healthy household lives. And that's the reality. So some of this will, the research shows this, but also I think what's important is to understand that context. And I know I probably am preaching to the choir here to many of you, but for those of you who aren't familiar with the military or the veteran lifestyle, I think it's important. Now, does their training mean that they are all violent? No. And I do know the fear around talking about this in the military space is we have a really terrible narrative at the moment. We have that they are all broken when we know they are not. We have that they are all suicidal when we know they are not. And now we have that they're all violent, which we know they are not. This is not a great narrative for recruitment. This is not a great narrative for a mother sending, a child to be in defense. It is a real struggle, but the reality is we have to understand the data, we have to actually look at the facts, we have to look at the context, and then and only then can we find solutions to these problems. And now that I'm off my soapbox, I will send it over to you, Sean.
Thanks, Gwen. I think you should stay on your soapbox because you find ways to use it incredibly effectively. And I'll tell you a bit of a story now just about some of this research, starting with some work we did a few years ago with the Atlas Institute for Veterans and Families, which is a Canadian knowledge mobilisation organisation. But just before we do that, just to flag the reason we've managed to get some traction with the research in an Australian setting, which we'll talk about shortly. The reason is because we've also had such incredible partners within DVA, and Gwen, it's no coincidence that we started to get traction when you came into your role as well. So I think there was also a confluence of factors, but I think also highlighting that the time is right for change. So we do have with the policy frameworks, with some of the data coming out and some of the personnel we have in different places, a real opportunity, I think, to shift the dial and to push this conversation in directions that maybe 6 or 7 years ago would not have been possible. But just going back to that international evidence base, I'm not going to talk about this too much, but where we started this work was, as I mentioned, in partnership with, so this is when I was employed at the Phoenix Australia Centre for Post-Traumatic Mental Health, a evidence synthesis project. So basically we were doing some evidence mapping. What did we know about family and domestic violence or intimate partner violence specifically in military personnel and veterans? And we basically did some what we call sort of systematic reviews. So this is where we do these really large searches of online databases, and we're basically looking to find all available evidence to get a sense of what that information environment is. So we did a review of all available surveys, population surveys and screening studies. Now this was, I think, published back in 2022, and it was looking at the prevalence, so how common was intimate partner violence amongst current and ex-serving personnel. Now, what we found from this is that if we looked at all available studies, we sort of synthesized them, we brought them together, and we basically took the average figure. We were looking at about 21% of all current personnel and veterans were reporting recent IPV exposure. So they were victimized, exposed to violence. So that's about 1 in 5. About 13% were reporting the use of IPV. So this was about 1 in 8. We were finding higher rates of IPV use in studies of ex-service personnel, as well as those conducted in specific health services. But critically, this evidence that we're finding was basically almost entirely from the US. So the US has a lot more resources than many other countries do for research onto a range of topics, but we basically had no Australian studies, and even within those US studies, very limited data on coercive controlling behaviours specifically. So when we're sort of looking at these prevalence rates, how common are these issues? Going back to my very early point about, well, we don't actually know much about what these experiences mean, the types of violence that is being captured by these surveys. That's really the current sort of international map, and it's one of the real challenges that we're trying to get around as well. So next slide, please. A second piece of work, or a second evidence map that we did, was really looking at, so not just how common is it, but what can we do about it? So the second review that we did was focusing on intervention approaches. And these were intervention approaches that were situated in military veteran-specific health services. So one of the contextual factors that was on the slide that Gwen spoke to was highlighting that there are veteran-specific services. Now, this is relatively unique to Australia and the US. In Australia, particularly following the Vietnam War, these types of veteran-specific services, for example, such as open arms, were sort of implemented with a recognition that military personnel and veterans have unique needs. They haven't necessarily evolved the same way in different countries. So, for example, in the UK, where there is a sort of really expansive national health service, there isn't such a long history of these veteran-specific services. But we were looking at these, well, firstly, because they are really salient in the US, Canada and Australia, but they also provide really unique opportunities for being able to identify and engage people, whether they're veterans, whether they're family members of veterans. So there are opportunities for engaging people in ways that might improve safety. So we were just looking at what did we know about, sort of the intervention options in this space. And what you can see on the right-hand side there is a bit of a summary of the sort of the intervention models that have been looked at in veteran-specific health services. So only 19 studies around the world, so quite a small evidence base. All of these were based in the US, so all in the Veterans Health Administration. So again, nothing in Australia. And the focus of these was mainly on what we would characterise as response programs. So if you are currently experiencing or using violence, a response to that particular issue, mainly focusing on victim survivors. So these were things like training programs for service providers, so case identification strategies, so sort of like screening programs. But also looking at sort of things like risk assessment, but also once we identify violence in a say a veteran-specific health service, what we do about it. Early interventions, so brief interventions, and then extended supports. There were a few examples for sort of veterans and military personnel that use violence, sort of men's behaviour change programs. So a very limited number that had been considered in veteran-specific services. So again, a major focus on the victim survivors of violence, nothing focusing on prevention, whether universal, selective, and also nothing focused on recovery. So some real gaps there in terms of family violence being a sort of major focus of trauma. But just to reiterate, all this evidence was being derived from the US. So again, gives us some ideas about some options that we might consider, but some real gaps in the Australian evidence base. Next slide, please. So that provided context for a project that was instigated with funding from the Defence Health Foundation, which is a defence industry insurer, which was then co-funded by the DVA Applied Research Program. And this was building off some initial conversations that me and my team had with DVA and Open Arms, and I'm pretty sure was driven pretty heavily by Gwen Cherne within the DVA circles. But it was about, okay, well, if there is a complete gap, if we know nothing about or systematically through research about intimate partner violence amongst veterans and families, where do we start? Where is the sort of the first cab off the rank? And where we settled was actually a project that was embedded within Open Arms, and it was really looking at service provider perspectives. So a really sort of, sensible starting point was just asking service providers, how often do you encounter clients who have disclosed violence, whether it's violence use or exposure? How confident do you feel? A range of questions like that. And we had, basically, we asked those questions in both surveys, and then we had some follow-up interviews with these service providers. And some of the key findings there you can see on the right-hand side. So the first thing, very top point there, is that, we weren't looking to uncover an issue that wasn't already being addressed. So, more than 83% of these service providers reported that their clients had recently disclosed being exposed to violence. 63% reported that recent clients in the past 6 months had reported having used violence. So this was already coming up routinely and regularly in clinical practice within open arms services. There was also, particularly from the surveys, the service providers really recognised that this was a common issue, and interestingly, they were really confident. They sort of felt that particularly for the clients who were exposed to violence, that they knew what to do about it, with some exceptions, and that was particularly to do about sort of looking at and assessing risk, particularly when there were children involved. And there was a lot less confidence about what to do with clients who reported using IPV. So, if we're thinking about addressing the use of IPV is actually a form of prevention, that's the source of the problem. That's where there was a sense of a lack of or lower levels of confidence or competence. In the interviews, these service providers also spoke about directly how they understood the military context as having implications for violence. And this was, for example, things about concern that if violence was disclosed, even in a healthcare encounter, that clients were concerned that this might trigger some form of notice to show cause, and this might actually increase safety risks rather than decrease them. So again, these weren't necessarily concerns that might come up for many clients, but they understood this as being an issue that would impact on potentially how clients disclose violence. But what we also found, for example, was that there was description of inconsistent approaches to risk and safety. So what practitioners were doing varied a lot. And the providers described very different lenses on how they understood violence. So if we toggle across to the next slide, please. We had, so just a couple of quotes. So we basically had two different groups of service providers, one of whom when we asked questions about how they understood violence, really spoke about sort of the mental health factors underlying violence. They spoke about things like poor attachment, poor self-esteem, childhood trauma. And there was another group who really spoke about what we might call sort of gendered issues, power dynamics, male-dominated environments and patriarchy, and how these were the underlying factors. And interestingly, what we also saw was that those service providers who described this sort of strong gendered understanding of violence were actually the ones who had experience working in the family violence sector. So it was a bit of a hit and miss in terms of what these service providers brought to the clinical encounter. Their histories and their training really had an impact on how they understood questions or how they understood violence. And we suspect, and we weren't able to unpack this in the study, that also had implications for then what they would do about it. So I think we might, in a moment, we'll sort of get across to talking a bit about the major research project that was published quite recently, but I think we might just take another pause for questions. Is that my understanding, Heidi?
Yes, thank you, Sean. We've had another couple of questions. Just going to throw back to you, Sean. How does it compare to the general population, these statistics? So sorry.
Yeah, so it varies depending on international context. So I might come back to the Australian comparison in a moment, just because we actually have that built in. But just before we do, from an international setting, I would just say the rates are substantially higher. It varies depending on sort of which country you're looking in, the types of violence you're measuring, but we are seeing elevations in these rates. And yeah, if you can bear with me for a few minutes when we get to the next part of the presentation, we've actually got some of those Australian comparisons in there, which might partly answer your question as well.
Gwen, is there anything you'd like to add to that? Okay. So Gwen, I'm going to lean to you while I've got you. Is there any guidelines in place where our veterans can source assistance from DVA and civilian services for a common and shared service, perhaps? You know, high developed communication between service providers type thing, so we, cross-pollination?
So that's a good question. I think what we're trying to do in the first instance, which I'll talk to a little bit later, some of the programs and services we're doing, but one of them is cultural competency, and things like having Sean go out and actually talk about this research and how it is different, and the unique nature of military service and violence that exists within our community, and make sure that our service providers understand, our whole of government, as Sean mentioned earlier, understands that and has cultural competency for military and veteran families, so they can start understanding and then developing that better. Do guidelines exist at the moment? Not that I know of. I do believe there are some information sheets, but frankly, we are still a grossly underserved community, which is why we're still trying to build that capacity. We're trying to put guidelines in place. We're trying to put information out there. I know Defense will talk later about their strategy and the action plans that will sit underneath it. And it's things like that that will be happening. The family strategy that we have in development for approval from the minister, and then the action plan that will sit under that also includes things like guidelines, research, programs, education for the community. And that includes, I sat in front of the Chief of Army's strategic planning day and, talk to them about this. None of them are experts in family domestic violence, because that isn't what they were trained to do or where their education is, nor should it be, perhaps. But what we do need to do is ensure that they understand it, that they not only have a module here and there, but if they can't, if they aren't experts in it, they have those quick guides and they have those phone numbers where we can actually get services and get good ones. And that stuff is still fledgling at this point. And people end up in this circular environment, as you probably already know.
Thank you. I'm just going to wrap up a couple of the thoughts and bubbling sort of comments here. How do you think we're going to tackle the fact that we're no longer a nuclear family, that families are more dynamic, they're trying to get the right term, more diverse? Yes, definitely. Is the term, and the focus on women becoming more redundant? Should we be looking at the whole ecosystem, not just one sex versus the other? I know that's quite a complex question, but if you have any thoughts, I would be willing to hear them. Thank you, Gwen, and Sean as well. Absolutely. I mean, families are incredibly diverse. We see it in like the work that Rachel through Deafless is doing is really important. We have Aboriginal Torres Strait Islander community who's been showing us this for centuries. The need to look at an individual and their family unit as it exists, not as a nuclear family, is something that is really important. Now, how we get government funding to actually recognize that is a bit of a struggle. But really, I do think we're moving along in doing that. We're looking at things like the new legislative reform that's coming through and ensuring that the primary carer of the veteran child gets the funding and the compensation payment
for that child, and it doesn't always go to the veteran because it is the primary carer, be that male or female. So we are looking at the implications of things like education schemes and how we ensure that no matter who is taking care of those children, they are supported and they are getting what they need, and that can't be taken away just because of a relationship or a relationship breakdown, etc. And we are a community of frequent relationship breakdowns, and that's the reality. It is not uncommon to us. So to be able to support multiple families that look varied and have different genders and sexes and all of these things is important, and is something that we are invested in doing as we move forward with all of the strategies and action plans.
And I might jump in as well, Gwen, and just like there is a I guess a temptation to talk about, for example, men versus women, and certain types of families versus another. That it's tempting. It's easy to see why we do this. If we show that sort of women have higher rates of exposure to family violence, does that build a case for more investment and more policy reform? There's a real downside to that as well, and I don't think we necessarily need to engage in that rhetoric and that sort of us versus them approach. These issues are often, and what we're seeing is that they're really common across different communities. And we're often using, for example, and what I'll speak about shortly, is some of the, how we're leveraging existing data sources, which, are broken up into neat divisions between men and women. And, frankly, most of the data that we have is about men and women in sort of, intact relationships. Our challenge is, I think, to use what we have in order to build that case. And if that comparison of men versus women, or even the community-based comparison, if we find out the rates of intimate partner violence exposure aren't elevated in veteran contexts, they're actually just similar, they're still high. These are still really sort of common issues that we need to get on top of. So I guess I would just caution that and just highlight, this is, I think, potentially where so, the research that I'm passionate about, I'm going to geek out in a moment, sort of go into some of the weeds of one of these studies. But this is the role of research, is then to generate the evidence that people like Gwen and Heidi, yourself, people in positions of authority can use to build a case, but then to really try and push those boundaries, to make visible the groups that are invisible, that are hidden. To basically give people like you the tools to be able to do that. So I think we can use the information and the impetus that we've got and the momentum that we've got. For example, even if it is with a preliminary focus on women's exposure to violence, we can address that while at the same time really trying to maintain that broad visibility, because we do know that these issues intersect and they affect multiple different groups, but we also know those groups often have different experiences and different needs. So our challenge then is to increasingly to try and understand those, so we can keep putting them on the radar, and shape the policies, shape the services that actually provide the supports that those communities need.
Thank you for that, Sean. There's a good segue in there. I'm just going to pick up one of the threads where you talked about data. If data was only gathered within open arms, for argument's sake, like the mental health service, how do you think the prevalence compares to the broader veteran population, given that you've just done in the weeds of a study? And who are not actually accessing the mental health services? And is there a correlation between mental health concerns and IPV?
Yeah, so don't actually have well, we do have a little bit of data on this that I can speak to, but maybe a simplification would be it's a bunch higher. But at the same point, like, that doesn't matter if it's 5% higher, is it 10% higher, if it's just high. Now, we just know, however, that these are common issues amongst clients in this service setting. Yeah, I think the exact degree of it, it probably doesn't matter too much if we just recognise that there's a need for a service response here. But yes, going back to your point, that we do know that there are strong connections with mental health problems. So for example, when we say that intimate partner violence is common in open arms services, these aren't typically people, however, who are seeking help for family violence. So the primary presenting problem will often be depression, anxiety, trauma, relationship problems, whatever the case may be. So the violence is often something that's underlying. So this then speaks to some of the service responses that we need to consider, which is how do we improve identification? How do we build the capacity of the service providers to recognise when there are risk signs of violence and then respond to it appropriately? And I think that speaks to some of the sort of the next steps for this program of work about what we actually do.
Gwen, is there anything you'd like to add before we move to the next slide?
I think I'm going to save it up to the end, actually, so that's okay.
Thank you, Sean. You have my full permission to get down into the weeds.
Okay, cool. All right, thank you for letting me geek out. So I won't go too much into the, it's a bit of detail on the slides, but I might skim over these reasonably quickly. So just to flag that after that project that we did, which was embedded in open arms services, so the surveys and interviews with service providers, DVA commissioned a second project, which was involving analysis of a big existing data set. Now this was described as labelled the Transition and Wellbeing Research Program, which was actually a series of studies that were conducted. It was sort of published back in 2015. So the data is getting a little bit old now, but basically there were these large surveys conducted of both transition personnel who had left full-time service between sort of 2010 and 2014. So there was about 4,500 participants in that study. A comparative sample of almost 6,000 current serving personnel who were current serving back in 2015. And these two samples of transitioned personnel and current serving personnel have been described as the Mental Health and Wellbeing Transition Study. So that's like one big chunk of this program. Now, there was a second component to the study, which is described as the Family Wellbeing Study. And basically those current and ex-serving personnel in the first part of the survey, some of them, or many of them, identified and gave consent for their partners to be contacted. And we had surveys available from 300 partners of the transitioned veterans and more than 600 partners of the current serving personnel. And I'll come back to it in a moment, but we could actually link some of those surveys as well. So we could connect both the veterans and their partners. But take-home message is that this is sort of 2015 data. There were questions about intimate partner violence exposure, which we'll look at in a moment. But large representative samples, particularly of the veterans and current serving personnel. So next slide, please. So I'll just highlight, there's a bit of methodological detail here, but just on the right-hand side, you'll see the questions that were actually included in these surveys. So this is from a horribly titled self-report survey called the Woman Abuse Screening Tool, which starts off in this instance with a preamble, thinking about your current partner. Okay, so this was only administered to people who were in current relationships. Please answer the following questions. Now, there were 8 questions that were asked. Now, we looked at these pretty closely and we just basically made a judgment call that the first 3 questions of this survey they were pretty ambiguous in terms of what they were asking about. In general, how would you describe your relationship? No tension to a lot of tension. A bit unclear whether this was actually an indication of violence or other sort of relationship difficulties. So we ended up limiting our analysis to the questions that are highlighted in red. So from this point forward, we're going to talk a bit about how common and some of these responses were. But when we're talking about intimate partner violence exposure here, we're talking about responses to the questions. For example, do arguments ever result in hitting, kicking, and pushing? Do you feel frightened by what your partner says or does? Which is a really powerful indicator of sort of coercive and controlling behaviours in particular. But then also what they describe as direct questions. Just has your partner ever abused you physically? Have they abused you emotionally or sexually? So really asking, so there's a bit of subjective judgment in people's responses to these questions, but effectively, the responses to these are men and women who are identifying that they have been abused. So if we move across to the next slide, might again just highlight some of the big limitations and caveats. So, we're going to spend a lot of time talking about the results, but just to be very mindful of some of the weaknesses of this. So our analyses are all based on cross-sectional data. So that, it means that all the questionnaires were all administered at one point in time, and we don't know anything about how these experiences have changed over time, and particularly since 2015. So we're obviously dealing with sort of intimate partner violence exposure for a particular cohort of veterans, many of whom had sort of deployment exposures in the Middle East. You know, we know less now about sort of more recent cohorts. The survey items only asked about current relationships, so we're actually missing violence linked to sort of recently terminated relationships, which is when we know there's actually an increase in violence. Critically, the questions weren't anchored to clear examples of behaviours and didn't ask about coercive and controlling behaviours in particular. So this continues to be a gap and something that we have some questions about. We also asked about the preamble, for example, to the questions asked about experiences in the current relationship. So we don't know when they occurred. These might have been recent, these might have been many years ago. We do, however, know that particularly coercive and controlling forms of violence tend to be long-term patterns of behaviour. So these don't tend to be things that sort of come up and then necessarily disappear. You know, but however, we still don't know much about the recency. And critically, the family wellbeing study in particular, so those surveys of partners, were not fully representative of the population of all partners. So, however, with those limitations and caveats in mind, I might just basically now, if we move on to the next slide, just to speak about some of the key findings. So, you know, headline findings. So, you know, how common is IPV exposure? So what we found is that when we looked at the high level, sort of how common these issues were, there were about 29% of transition personnel who reported any IPV exposure in their current relationship. And this was compared to about 22.5% among current personnel. So this transition versus current personnel comparison, I think, highlights the challenge that I was raising before about, you know, do we actually need to compare groups? You know, so we've got evidence here that the rates are higher in veterans or ex-service personnel, but this suggests they're also very high amongst current serving personnel, so more than 1 in 5. So we just need to be cautious about those comparisons. Critically, also, we find that they were high amongst both men and women. So there was sort of similar rates of about 30% for both groups that were reporting IPV exposure. Now, again, mindful that we don't know much about what people meant when they were answering these questions and the types of violence they were referring to. These were, however, suggesting high rates. And we found that the rates were even higher and alarmingly so amongst the partners of transition personnel. So again, mindful of the caveats, these aren't fully representative, but we had 45.5% of the partners of transitioned personnel who had left the Defence Force in the past 5 years were reporting any IPV exposure. And this was compared to about 24%, so almost sort of 1 in 4 among partners of current personnel. And in this context, we also found that emotional IPV was the most common form endorsed. So the sort of the last example there, so there was 26.6% of these transition personnel who reported emotional IPV relative to almost 10% that reported physical violence. So physical violence was still common, 10% was still sort of 1 in 10. Those are sort of elevated and high rates. But the most common form that we were finding was emotional dimensions of violence. And going back to the earlier question just about community comparisons, so there are no studies from Australia that have actually used that particular measure. So it's a bit difficult to compare like for like, but we do know that about the same time as this survey was conducted, the Personal Safety Survey is a large-scale community-based research initiative on family violence in the general population. There was one conducted back in 2016, and this reported that about 3.2% of women and about 3% of men reported experiencing emotional IPV by a current partner in the last year, and about 1.4% of women and less than 1% of men reported exposure to physical violence. So again, the comparisons are imperfect, but they do highlight what appear to be fairly significant elevations in this veteran and military sample. So next slide, please. So some of the other sort of major findings that we took from this report, which this report, by the way, is available on the Open Arms and the DVA website. So this is now all firmly in the public domain. So first of all is that there was evidence of both risk and protective factors. So there were groups who were reporting higher versus lower rates of intimate partner violence exposure. So what we found was that there were higher rates of IPV exposure reported in the context of particular financial and economic difficulties, high rates of trauma exposure. So those groups were more likely to report IPV. Protective factors were associated with social connections and resources. So, levels of social support, the numbers of friends that you had in your community appeared to be protective. Critically, we also saw evidence of really strong mental health and psychosocial correlates in particular. So both the transition personnel, so the transition veterans and partners who reported IPV reported really high elevations in risk of probable PTSD. So this goes back to, again, an earlier question about the mental health links. These were sort of almost 3 to 4-fold increases in risk of probable PTSD, and really strong increases in the risk of suicidality. And we also looked at these associations separately across men and women, and there were some slight differences, but those pattern of associations were holding for both the genders there. So we were seeing for both men and women, there was really strong risks associated with IPV of mental health and psychosocial adverse consequences. And critical, we also did what we described as benchmarking, which is that we actually compared the magnitude, so how strong those associations were with, say, intimate partner violence and PTSD symptoms and suicidality with family violence exposure relative to other types of trauma, both military and non-military, that we often consider in this context. And what we saw was, almost without exception, that the links with IPV and PTSD symptoms and suicidality were actually stronger than associations with most other forms of trauma. So if we're thinking of IPV as a risk factor for post-traumatic mental health outcomes, it was emerging as being a much more influential factor than other forms of trauma that we're commonly seeing, which again speaks to this interpretation of intimate partner violence and family violence as being a long-term pattern of coercive and controlling behaviours. It makes a lot of sense, unfortunately, in that context. And the final, on a slightly more positive note, we did also have some really interesting findings regarding IPV and help seeking. So particularly with men, often sort of veterans as well, it's actually really hard to identify, them in service use contexts where we can actually deliver help. What we found in this particular series of samples was that most of the men and women veterans in particular who were reporting IPV exposure were sort of recent, commonly encountered in health services. So, for example, almost 90% had reported visiting a GP in the past year. But 40% had, in the past 12 months, had accessed a mental health service. So this speaks to the context that these individuals are likely to be identified and encountered in. And these are all opportunities. These are opportunities for identifying and doing something about it. Next slide, please. And then I think I'm not far from being done. The final piece of the empirical part, so the actual research here, which I want to talk about, is the surveys that could actually link veterans with their partners. Now, if you recall, most of the all the survey data was spoken about this up to this point has been about exposure to IPV. So I'm a transition veteran and my partner did this to me. We were actually able, by linking up partner reports of IPV exposure, we were also able to look at the use of violence by veterans as identified by their partners. So this is sort of the only part of this presentation that will speak to the use of violence. Really novel, because often how this is measured is actually by asking people themselves, have you used violence? So this is actually identified by asking their partners. And what we found was basically, so those veterans who were identified as using IPV, as identified by their partners, were reporting really complex mental health profiles. So super high rates of harmful drinking, suicidal ideation, depression, anger, and PTSD. So really common severe co-occurring issues. But critically also, we're reporting really high rates of accessing mental health services and other health professionals. So again, this is a really critical important, particularly about those sort of young men who we find are typically difficult to engage. They usually, in non-military veterans settings, often don't go to see the GP, for example. We're finding that in this case that those who had reported or identified as using violence, for example, more than 90% had visited a GP in the past year, 50% had visited a dentist. which is an interesting sort of service provision context to think about delivering maybe interventions and training. But more than a third had visited a psychologist. So again, speaking to this notion of like, well, now that we know these people are out there, how do we actually engage them in order to intervene early to both reduce their mental health risks, but also their risks of using violence? We do have opportunities in this space that are maybe difficult to envisage in other settings. And next slide, please. So this is more my final slide before we pause for questions, and then we get to hear Gwen back on her soapbox, which I'm sure we're all looking forward to hearing. But so just by way of a summary of these findings, because I realised there was a lot of sort of in the weed data there. You know, my take-home messages from this are, first of all, you know, intimate partner violence is common in this setting. And yes, it's probably elevated, but to some extent, it doesn't really matter how much elevated it is. These are common issues. And they're common across the groups that we looked at. So both transition and current personnel, as well as the partners of these groups, as well as the partners of these personnel, women and men. And even though emotional IPV was most common, physical IPV was also, you know, we might describe this as non-trivial. These rates were high. There were risk and protective factors that we could identify, particularly speaking to, you know, economic disadvantage, financial hardship, but also resources. You know, sort of community and relationships were associated with lower rates. And we also saw that there were links with engagement with veteran-specific services. So these were opportunities for doing something about it. Really strong links with adverse mental health and psychosocial outcomes, particularly suicide risk and PTSD. And we saw these links with mental health for both those who've been exposed to IPV and those who use violence. And in particular, these sort of really complex mental health profiles highlight, I think, a challenging client that we need to anticipate in these service contexts. So I might take a breath there, Heidi, for questions if we have any.
Thank you, Sean. I'm actually going to be very cruel because I'm time watching or clock watching. I'm going to hold them over, and I'm going to hope that Gwen actually answers a lot of the questions that are coming through her little lived experience conversation. So Gwen, I'm going to hand over to you and let you kick off. Thank you.
Thanks, everyone. Thank you so much, Sean. That was really enlightening. And it was a lot of numbers. And I think it's really important that we put this back into a human context. There would be people on the line who are victim survivors, be it of parental or other intimate partner violence, etc. And I just want to take a moment to acknowledge that, you know, people like you who are out there, myself, my children, we are part of those numbers. And one thing I want to mention is, you know, 1 in 3 children who experience violence become perpetrators of violence. And, you know, someone, and also give some context, it takes 11 to 14 times, often a decade, to leave a violent relationship. And, you know, we're not talking about people who are unlike ourselves. And the reason that I'll share a bit of my story now is because I think it's important to put it into context of, you know, we were one of those numbers. And, you know, there is I went through, my father was a Vietnam veteran with post-traumatic stress, and we experienced an enormous amount of emotional and physical violence in my home growing up. I experienced sexual violence as a young adult. I experienced intimate partner violence with my late husband before he died in 2017, and tried a number of times to leave. And that was after 4 years of intensive individual and group therapy in New York City, and then other therapy here, and, you know, multiple degrees and lots of financial stability on my own. And yet I was still susceptible to that line in the sand, consistently moving slowly and slowly and slowly, and trying to break out of that cycle where it would get worse and worse. Until I absolutely had to leave, and then the services were simply not there when I tried to leave at the end. So I want to really ground this back in the fact that these are individuals with individual stories who are, you know, with high thresholds of duty and honor and sacrifice behind them, going, I don't want to leave. I want this to work. And our service providers and our services are not equipped to provide these families who want to recover, who want to prevent this from happening, to actually succeed. So I want to talk briefly just about some of the things that are going on, so that I can answer hopefully some of your questions. DVA has a family domestic violence strategy and an implementation group. They are currently investigating whether and reviewing it to see what the lessons from that strategy have been, how effective it was, and then trying to bring together stakeholders from across the agency to get better tangible outcomes for veterans and their families who are exposed to it. They've provided a number of commitments to the national plan to end violence against women in accordance with 4 of those domains: prevention, early intervention, response, recovery, and healing. And that acknowledges not only that families are a cohort that experience it in exclusive and compounding ways, but therefore should have better targeted programs to get better outcomes. DVA is reviewing its internal family domestic violence resources, educational resources, to better equip their staff in identifying it and dealing with it. And they're coming up with they have a veteran and family specific communications plan that is currently in front of the executive management board, and it aims to educate the client cohort around family domestic violence and promote access to those services. So those guidelines that someone had mentioned earlier on. And then Sean and I both sit on a community practice with Kath Allen, thanks to RSL Life Care, that brings together government and non-government agencies invested in achieving best practice. On the defense side, I just want to talk about that for a minute. They defense strategy for preventing and responding to family and domestic violence 2023 to 2028 aligns with the national plan. The strategy was released on 30 November 2023, and it articulates Defense's commitment to prevent family domestic violence in our community and to provide well-being and recovery for those affected. It builds on the initial one from 2017 to 2022, and sorry, just trying to rush through some of these notes so we have time for questions. And will be supported by an action plan. There we go. And that action plan is being finalized. One of the last things that I want to talk about is that there's a lot of, there's some really, really great work. You know, Sean, when you were talking about, it's not men against women, it's you know, victims and perpetrators, and allowing, like, stigma is huge. How do we get people in the room to, one, admit that they're violent, or to ask for help? And, you know, we have broken down stigma around mental health. We have broken down stigma around alcoholism. We're breaking it down with gambling. We really, really are still not there with family domestic violence and intimate partner violence. And that is something that we need to actually stop judging and start providing people with help. Now, it's also a crime in some cases, and I believe that wholeheartedly. But programs like what we're doing, what DVA, and I say we because I get to be involved in it, is doing in Tasmania on the foundations of functioning. It is going to take us, a group of humans and veterans and veteran families, and allow them the opportunity to figure out how to better be in relationship, how to emotionally regulate. And then it will be a pathway into potentially other programs. So if we are creating safe spaces for people to go, I'm not faring in these areas that are acceptable to struggle in, we will then have pathways into anger management, into better, more self-regulation, into intimate partner violence support groups. And, you know, there are programs like Love Bites in New South Wales. The Family Code is a great recovery program for families of domestic violence. You know, and for those of us, and I say this because I think it's important to reduce stigma, I fight being a perpetrator every single day of my life. It was ingrained in me. It made me survive that I have a fight response to every threat that exists, be it a child acting out or something going wrong in my household or a partner who is intimidating me. That fight reflex is a superhighway, but that means I had to go and do training and therapy and education, and I have to meditate every morning. It's in my schedule. Thank you, Heidi. Because what that means is that I manage it and I don't become a perpetrator for my children. And when I get wobbly, I have to take that time and space to regroup, because that isn't okay. But I also have to talk about it. I also have to talk about how hard it is, so that people don't feel alone or like they're the only ones struggling with this. This is rampant in our community. It is rampant in our society. And until we actually put our hands up and say, I struggle with this stuff, we are not going to solve this problem. And now I'm going to open it up for questions. And please, if I don't say it later on, join us for more of our community of practice. We're doing more webinars. We've got all sorts of really great topics. So if this is something that comes across your desk very often, please join us. There'll be 20-minute sessions and 20 minutes off. I'm done.
Thank you, Gwen. We've got a couple of minutes, and I appreciate it's very late in the evening for everyone. So if I don't get to all your questions, people, we will try and answer them post this session and pop them up when we publish the recording from this evening. Gwen, I'm going to put it to you in the first instance, just because you have just finished chatting, right, and you're already on the front foot. Excellent. How do you see these services in the general community as opposed to veteran-specific services? Is there a need for specific services, or just cultural awareness through military aware service in the community?
I think it's both. And I think we have got to come at it from every angle. I think choice is frankly the most important thing. Some veterans and families want to go in and be a part of veteran-specific or military-specific environments, and some want nothing to do with it because it has been such an unhealthy place, or they just don't identify that way. We have to provide both. Sean, over to you.
Yeah, I was also going to I agree with that wholeheartedly, Gwen, and flag that there are also opportunities for doing things in the veteran-specific service sector that might be really difficult to implement in other contexts. So if we're thinking about, you know, obviously what we're doing at the moment isn't working, or it's not working enough. So we need to be thinking out of the box. We need to be trialing new and innovative ideas. So, you know, the veteran-specific service system is a really interesting context because, for example, a lot of the mental health and trauma issues that you're speaking about, Gwen, arguably, you know, sort of management of those issues is already embedded in the sector. So we've got a really novel opportunity to look at, okay, well, what happens if we start to embed different types of behaviour change programs in a service sector that does actively manage underlying mental health problems and trauma? Now, we need to do that carefully, and we need to sort of look closely at whether those initiatives work. But we might find those types of programs even really difficult to look at in any other service sector. So if we're thinking about a context that can really push the boundaries for testing novel solutions and really trying to, you know, address this in different ways that might enhance and complement what we're already doing in non-military services, you know, I think we've got a really receptive setting there.
Thank you, Sean. Last question of the day before we let everyone get on with their evening. Is there anything specific that we should be looking at in regards around our children in the intervention strategies? Gwen, you just mentioned about how you're hardwired and the work that you do so that you don't pass that on to your children. Is there anything else that we should be looking at as policymakers and change makers that we should be trying to foster?
Look, I think, thanks, Heidi. That's a great question. And one, if I had another hour to talk about, I could do, but I will keep it brief. As a child who experienced violence, I didn't understand boundaries. I didn't understand when people were crossing them, and I didn't understand how to set them because I was like absolutely obsessed with making everyone happy in my life. So teaching, and this is really common, it goes back to that Love Bites program that I was talking about. What are appropriate boundaries? What is a healthy relationship? And how to say, no, I don't want you to do that without feeling badly because you've made someone else feel bad. We don't, as kids, we teach them too often that they're to be people pleasers. We don't want to do that. And then we end up sort of perpetuating this cycle of not understanding what healthy relationships and boundaries look like. And that is one of the best kinds of programs that I think we can give them, because then it moves into those conversations around consent when they get older and protecting them from, sexual perpetrators and other things that they will inevitably be exposed to throughout their lives.
And if I can jump in as well, Gwen, I know there is in the broader family violence policy space, there is an increasing push, which I think is critically important, to recognise children as victims in their own right. Mm-hmm. Now, it's crazy to think that we're not doing that already, just given the sort of short-term and long-term mental health and psychosocial consequences that you're talking about, Gwen. And I guess it's the risk of, by focusing on one type of person who's been exposed, by focusing on women, for example, who've been exposed to violence, it does lead to a neglect of other groups. So there is, in that broader space, there is just we just need to recognise that these children are, victims themselves. In that non-military sector, we haven't really gone much beyond that yet. So it's not like sort of the veteran military space is lagging far behind. This is a general challenge, which is that in the context of constrained resources, and there's not enough money and funding for anything really. How do we actually operationalize a response? How do we actually do something in order to make these children visible? I guess the first part is just having this conversation. And Gwen, I just think, as per usual, I always love presenting with you, just because sort of you speak to the and you paint a picture of what these impacts and consequences and what the lived experience is. So I think just having these conversations and these sorts of questions is probably that first starting point.
Thank you, Sean. I'm going to cut in and jump in there. I'm just going to say thank you to everyone who joined us this evening. There's a couple of questions we didn't get to today. I will do my best to answer them after this and publish them when we publish the live event. Once again, thanks again on behalf of the Veterans Family Guild for hosting this evening, and our wonderful presenters Gwen Cherne and Dr. Sean Cowlishaw for joining us today. If at all you found this evening distressing, emotionally challenging or triggering, please speak with your health professional or your manager, or friends or family, or make use of 1800 Respect, Men's Line Australia, Open Arms, Veteran Families and Counselling. Please take care of yourself, and we thank you again for joining us this evening. Please have a wonderful evening.